So, Dr. Essebag, you presented the results of the combined analysis of Bruise 1 and Bruise 2 at EHRA 2018. Can you tell us a little bit about the analysis and the trials?
Yes, so the Bruise Control 1 study demonstrated that operating for cardiac implantable devices without interrupting warfarin was far superior to the prior standard of heparin bridging. There was a reduction by 80% of the risk of clinically significant hematoma. In Bruise Control 2, we looked at the question with DOACs, comparing interrupted versus uninterrupted DOACs, and in that study we found no difference in the risk of hematoma. In this combined analysis, we looked at patient-level data from all patients in both trials to look at predictors of clinically significant hematoma. We found that bridging compared to continued warfarin increased the risk by 6-fold of clinically significant hematoma.
Yeah.
We did not find any difference when we compared continued warfarin to DOAC therapy, which is interesting. And the most interesting point was really that the use of any antiplatelet agent in conjunction with the oral anticoagulant doubled the risk of clinically significant hematoma, no matter which arm the patients were randomized to.
Yeah, so this is quite reassuring, and also I saw in your slides that people who continued DOAC versus interrupted DOAC, there was no difference.
There was no significant, so
the hematoma rate.
Yeah, and that could be interpreted in two ways. One way is, if you're concerned about the risk of stroke in your patient, if they're a highish risk of stroke, then there's no reason to hold any dose of the DOAC, and you can do the procedure without an increased risk of hematoma. If a patient is very low risk and one wishes to hold a dose, or the operator has some concern, well then, again, there's no difference in the hematoma rate with a very brief interruption of the DOAC.
Yeah. So I think one of the big take-home messages from this is really that antiplatelets are bad when it comes to hematoma.
That's right. So antiplatelets are bad, especially when it's associated with an oral anticoagulant. All the newest guidelines in atrial fibrillation patients with antiplatelet therapy for other reasons, post PCI or ACS, the newest guidelines strongly, recommend discontinuation of the antiplatelets after a period of time, depending on the specific criteria. And I think it's important to assess the patient when they're coming for an elective procedure. Oftentimes, I think the antiplatelet agent that they're on is no longer based on a current indication, and one can reduce hematoma significantly by withholding the antiplatelet for a week and probably get more benefit out of that intervention than deciding whether or not to skip a dose of the DOAC. So I think it's very important to assess the patient in that regard.
Yeah, I think these were very well conducted studies. I noted on your slide that the clinicians were blinded to what anticoagulation regime the patients were on.
So the operator knew, but the physicians and the study team that assessed the patient post-operatively, that adjudicated presence of hematoma and managed the hematoma, that was all by a blinded team. So that the endpoint was a blinded endpoint in that regard.
And in the warfarin group, did you have many patients with mechanical valves? Because often they can be the most tricky to manage.
That's correct. So the Bruise Control 1 included any patient on warfarin. So there was, I forget the percent, but it's in the paper, at least a quarter or a third of patients had mechanical valves. That patient population was not evaluated in Bruise 2 because DOACs aren't used. But some of those patients had higher target INRs, and the use of antiplatelet agents in Bruise 1 was about 40% of the population. So when you look at the rate of hematoma with continued warfarin in Bruise Control 1, it appeared numerically higher than the rates we saw in Bruise 2, but there was 40% antiplatelet use in Bruise 1 as opposed to about 20% antiplatelet use in Bruise 2. So I think the difference is largely related to differences in antiplatelet use. Some of that because of changes over time in guidelines, and some of that may be differences in patient population.
Okay. So I think these are important clinically relevant study results. I think potentially they're going to change practice, because I think a lot of people have been hesitant to continue DOACs when they are implanting CIDs. But I guess the message is actually
the message is you may continue the DOAC. That's not going to cause hematomas, but focus a lot on the antiplatelets, especially when the indication for them is no longer strongly present, and consideration of withholding the antiplatelet is something that should be done.
Excellent. Dr. Essebag,
Thank you very much. I'd like to thank my co-principal investigators, David Burney, Jeff Healy, and all the investigators, coordinators, and patients who are involved in both trials for an excellent collaboration.